Good afternoon, everyone. Thank you for joining today's webinar on managing your revenue cycle's response to COVID-19, hosted by Guidehouse. Please note that all lines have been placed on mute to prevent any background noise. If you would like to ask a question, you may do so via the Q&A feature in your GoToWebinar dashboard, or you may use the raise your hand feature to ask your question via telephone. Once our speakers have concluded, we will compile the Q&A roster. Please also note that the call is being recorded and all materials will be made available and sent out as soon as possible. I will now turn the call over to Mr. Tim Kinney. Go ahead, Tim.
Thank you, Rebecca. And thank you all for taking the time out of your busy day to connect with us today. My name is Tim Kinney. I am a partner with Guidehouse and run our revenue cycle practice. First and foremost, I wanted to take a minute to thank all of you as you're battling the coronavirus. Whether that's on the front line or the support that RevCycle gives through patient access, the middle revenue cycle, the back end, or leadership overall. One note, as you guys are probably aware, a lot more telecommuting. So if we run into issues with the webinar, we'll make sure to get that up and going just as quickly as we can, but might be a little bit slow from a transition perspective as well. Our intent today is really to provide everybody on the call with useful information and tactics that you guys can act on, that we have seen and compiled this information to make sure it's hopefully impactful to each of you that are running the rev cycle or serving in a leadership position within the rev cycle. One other thing we will throw out there is we are updating our information daily for those of you guys that are following. Whether it be coding information, billing information, reimbursement information from CMS and Medicare, it is changing rapidly. So our commitment is to stay on top of that and make sure that we're pushing information through this and then through a series of webinars that we plan on doing as well. Next slide, Rebecca. Quick agenda for today, just to set the stage. We're going to spend the next hour or so talking through revenue cycle continuity plans. So what should we focus on to make sure that we're continuing to run the business aspect of it, able to operate the rev cycle in a go forward fashion. And then we'll turn it over to our team that has deep expertise in the coding side of the fence, talk through some of the guidelines, the impact from the coronavirus and how that is going to affect coding. We'll do the same thing for billing recommendations and get pretty detailed in terms of what we're seeing across the country, the specific billing stipulations. And then lastly, we'll have a point on there where we're just going to talk through some of the scenarios that we're seeing, some of the unintended impacts, the lessons learned that we've seen. And then we encourage you guys through the process, think through questions and answers. Q&A, we'll open it up and be ready to go and answer those questions and make sure we follow up appropriately with anything after the webinar as well. Next slide. With me today, I introduced myself. We have Brian Chamberlain. He's a partner in our firm. He's going to take us through the continuity plan, deep expertise within rev cycle. We have Ian Stewart joining us as well, longtime revenue cycle professional, and then probably in the trenches more than anyone right now from a revenue cycle perspective, billing, follow-up, etc. And then Amanda's going to also give us some insight on the billing and clinical integrity piece specific to coding as well. So again, I appreciate everyone's time. The last thing I will say is we'll make sure that we send an email after this with the toolkit that we go through, so you guys will have it as well. But hoping that you can take something meaningful and actionable out of this. And with that, I'll turn it over to Brian.
Hey, thanks, Tim. Just want to make sure everybody can hear me here. If you can't, somebody just kind of raise their hand. But really wanted to just take it from there and talk a little bit about a high level around what we're seeing our clients do from just a challenge standpoint of getting things to the remote environment and enacting some of the business continuity plans that they've either had to dust off a bit, or they just found out that what they had was not necessarily up to date and they're having to kind of recreate from scratch. So with that, we've shared a couple of things with our clients of just identifying those top activities within the revenue cycle that can be moved to remote capacity, and then how do we pivot and get people to help out in areas that they may not be primarily focused on, but the work is shifting. So we know that, for example, you still got all of your current AR management that's being done. And typically that stuff, to the extent that IT can handle remote capacity, is able to get folks to access your systems, your EHR, all of your tools, working with vendors in a little bit of an easier remote fashion than your frontline staff. So, we even think about scheduling and moving to telehealth. We're finding a lot of folks that having to reach out to patients and adjust or set up those types of visits. And in some cases, the AR management team or the billing teams are able to step in and follow some of the scripting that may be in place to support those folks to move rapidly into those changes and not have to have any further reduction in schedules in a more short-term approach. So we know that there's a lot of things happening, a lot of variety of work. The IT team is also in some ways, in some of our clients, is the limiting factor. A lot of these organizations, and you guys may be in some of these situations with your own environments, is IT just isn't used to handling this level of change this quickly. Really a lot of organizations handle the day-to-day and system migrations and updates very well, but when it comes to moving a whole host of individuals off to a remote capacity, we think about things just around laptops and VPNs and how do you handle PHI. All of these are having to be addressed, and there's no one size fits all, but there certainly is just applications of your existing policies and procedures and making sure that they apply to folks that may be in a remote environment, and then having the check-in to ensure that those folks are able to work in those environments, and then have flexibility too. We'll talk a little bit about the adjustments to what that means as we're all kind of living in this new normal right now of managing performance and being flexible in that, and really thinking about it at a higher level. And certainly have to do performance management at a staff or a department level, but thinking about maybe the more, what's the weekly goal, what's the next 30-day goal, and pivoting a bit around that is needed. The other things that I'd probably say here is just, we talked about the flexibility, is HR. I mean, we know at this time HR is critical in helping to define these changes for folks. And there's a lot of organizations and clients that we've worked with that, they're either adapting to that remote environment, they're adapting to changes in, maybe job descriptions. And in some of this stuff, we've got organizations, you guys may have be a union environment, those have special considerations as well. So if you're asking somebody to step into a different role to support, is that above or below their current pay grade? And how do the organizations then handle that? Is there a special consideration or contingency that is set up to allow for that? And if not, what's the leadership message from you all, as well as maybe senior leadership of the organization, and getting people to pitch in and help figure some of this stuff out maybe later, hopefully not too much later, but kind of act with the issues at hand today, and then address some of the changes that are going to be in good faith over the next 30, 60 days as all of this stuff flushes out. So next slide, please. On this slide, just really kind of buckets a few of those aspects of the business continuity plan into quadrants, and probably nothing surprising here, but we know the technology setup is key. We're all in a very technology heavy environment these days, and live and die by the systems that we're in, and that has to be migrated, that has to be accessible, it has to function into that remote environment. We mentioned the privacy concerns and having the right level of access, but then also managing who has the access and being able to track where needed, where folks are accessing the systems. Of course, phasing it. We've seen that not everybody is able to move in an overnight fashion. So having a plan to structure this and what makes the most sense. We talked about, or I mentioned, moving some of the billing and collection teams, maybe to phase one, and then having folks that, if you just think about another example, handling correspondence, right? Those are going to come and be received through the organization each day and need to be managed, and understanding that you're going to need to have some level of critical staff on site. And how do you handle some of those? Or is it, maybe even a different work schedule, so they're not coming in Monday through Friday, but coming in a couple of days a week to handle some of those critical tasks. Performance indicators, the flexibility there that I mentioned, those are often, we've seen easily transferable from what you're all managing in your current environments. just another layer of complexity to get to some of that data, put it together, and of course be flexible, knowing that schedules may be adjusted. You may have people working in different areas of your revenue cycle, and so that the KPIs are going to be a bit fluid, and you may have to do some more granular review to understand what's happening on a week-to-week basis. But the flexibility there is key, and just kind of understanding, do you have the right people in your analyst team to do that level, and do they understand what's going on? So keeping them informed is very key. And then that kind of brings us to the last quadrant here, is just really effective communication. And do you have escalation process? It's one thing that there's an organizational wide communication, but we all know, and people want to hear it as you as leaders, and how your team's doing, and do they have the right escalation with questions? And they may not have answers every day, but working in a remote fashion or working in a different environment, there's going to be those questions, and it may not be as easy as walking down the hall and stepping into one of your all's office to understand the answer to that. And how are we using the tools and the technology, all the various WebEx, Skypes, instant messaging, of course, email, just making sure that people are comfortable with those and have the right level of accessibility. And then kind of triaging and prioritizing some of those requests and questions that come in. I think with that, the only other addition I would say is probably just be patient with a lot of this. What we've seen is the business continuity plans are in various levels of maturity that we've typically seen, and it's really unprecedented. It's a word used a lot these days, but most places have not had to dust off these disaster planning or business continuity plans and having to adapt very quickly. So we've seen very high level of success of people rising to the occasion, but certainly a lot of detail to figure out, and just try to be gradual where they can to comply with all the mandates that are out there and the right thing to do for the workers. So definitely, communication is key, and I'll kind of end on that note. Over communicate, over analyze where you can, but be flexible. And we've seen that kind of be beneficial, and we've kind of developed a checklist that we'll share as part of our package that just gives a little bit of idea of what tasks are critical that hopefully you'll find helpful to embed into your business continuity plan overall. All right, and with that, I'll pass it over to Amanda.
Thanks, Brian. In addition to myself, we also have two of our colleagues on the line as well, Sue Egan and Tess Turry. Both of them are coding specialists with our group and have been the face of the coding updates for us. And so as we have any coding specific questions that are coming up, I'm going to engage them to help answer some of those for the group. So coding guidelines that have been effective since April 1st, earlier this week or yesterday. The first one, a new ICD-10 code, your diagnosis code here is the U07.1, the COVID-19 code that has been confirmed by laboratory testing. There's also a new CPT code for laboratory testing related to COVID-19, and that CPT is 87635. Again, in defining infectious disease agents that you're finding, severe acute respiratory syndrome, and others. So really what we want to focus on is using the CPT code to help you all report and track your testing services that are related to the SARS COVID-19 test. Really to help you all and making sure that you're setting up reporting around this for your reimbursement efforts related for testing and keeping track of your volume here. And then again, for specific information, you're going to want to reach out to your local third-party payers to better understand their specific guidelines as related to the CPT code, since it can change depending on where you are across the country. So the final, if you're taking multiple and separate specimens for that virus on that same patient and it's occurring within the same day, an example we gave here, right, are, you're taking it, the nasal, or you're taking the swabs through your throat. you want to report those codes with the 59 modifier on them. Another update are on 2 CPT codes that are currently being fast-tracked related to COVID-19 testing. The first code is the U0001, and that's for the CDC testing laboratories. And then the U0002 is specific and related to the non-CDC laboratory testing for these items here. So again, as a very high level, I know Tim mentioned it earlier, but these things are, coding, these updates are coming through on a daily basis, and our team is trying to stay on top of these items as quickly as possible. Now, if there are any questions, please go ahead and message them in, or we'll have some time later in the presentation. But if you have any questions around, the specific diagnosis related to COVID-19 or the new lab code, we'd be happy to answer that for you. Rebecca, perfect. The next 2 slides we have here are specific to telemedicine updates. As I'm sure you're all aware, we've seen quite a few changes in the telemedicine market, both in the coding realm as well as the reimbursement realm on the end. So we're going to talk about both of those. So there are some new flexibility with telemedicine coding and billing here. They have added 80 additional telemedicine codes that now have expanded coverage for services to include home visits, ED visits, and therapy services as well. From the reading and what we're seeing on CMS, that providers currently, you all can choose to waive your copays for the telemedicine services for your Medicare beneficiaries through this time. Virtual check-ins, another update here, it has been extended to new patients as well as your established patients on here. Additional considerations that have been coming out through telemedicine. The first one is supervision. So CMS is now allowing physicians to supervise other clinical staff that are using these virtual technologies when appropriate and or when absolutely necessary, right? They cannot be there. Again, so definitely check in and make sure with, again, your local MAC, so this is something your group, your provider market can do. And then the Stark Law waivers, they are exempting providers from sanctions of non-compliance against certain Stark laws. Again, we have more details and information in this area too, if you're interested, but specifically it's allowing for certain referrals or submission of related claims that normally would be in violation of this law. They're waiving that for the time being through this emergency that we're seeing. The next section specific on billing. So again, some fine print when you're looking at actually billing out these telemedicine services that you're seeing here. So again, you can actually go back and not necessarily backdate, but look at services that started as early as March 1st, 2020, throughout however long they declare this public emergency to be. So when you are billing these, you can use your PPOS equal to what it would have been in the absence of the emergency that we're currently in. You just need to make sure that you're adding the modifier 95 to those. CMS is also not requiring the CR modifier on your telemedicine services claims. So for your traditional Medicare telemedicine services, use the place of service 2 on your professional claims to indicate that this was furnished by a professional telemedicine service. There is no change to a facility, non-facility payment differential based on the point of place of service that you are going to be submitting on those claims. So the place of service 2 will continue to pay out or be reimbursed at that facility rate. As for institutional claims, there are going to be no billing changes that are required when you are billing the critical access hospital method 2 claims. Again, continue to bill these with a GT modifier as you have been. Now, there are some additional updates on the telemedicine billing that Ian's going to get into when he starts talking about, other considerations around billing. But it is critical in this time, not just for your telemedicine services or your COVID-19, but that you are placing an emphasis on stopping and reviewing these accounts to make sure that assignment of proper diagnoses are happening, as well as assignment of proper, charge codes in place of service. I know that there has been a daily, it feels like, onslaught of changes that have been coming out from CMS and others regarding how to code and bill for these. And so there are places, on the CMS websites or others that very clearly outline and provide direction on how to approach all of these. But again, because reimbursement's changing and because coding is changing, it's important that for all of your facility, there are holds being put in place that are stopping all of these accounts prior to going out to these payers so that you all are having an opportunity to review for accuracy. It could definitely make the difference from a reimbursement and, up to 5 times that reimbursement that you were receiving prior to this public health emergency. And with that said, I will turn it over to Ian to talk about billing recommendations.
Amanda, thank you. Hey, welcome. My name's Ian Stewart. I'm a managing director with about 20 years of large system end-to-end rev cycle work, mostly in Chicago. I joined Navigant about a year ago, and I've spent the last number of weeks really on the front line, moving staff, working on changing volume, shifting how and where work's done, changing billing activities, and in parallel, as most folks are focused on staff furloughs, reductions, cost cutting to deal with COVID-19 on the ramp down. And then for one place, ramping back up once COVID hits. So I'm going to spend the next maybe 5 or 10 minutes just talking about things I've seen and really walk through some of the things I think you should be thinking about. And so kind of pursuant to Amanda's points, things are changing very quickly. So one recommendation is really to hold our claims by payer until all of the known recommendations and really processes that those payers will undoubtedly give to you and then change probably at some point will be able to be held so that you can bill and adjudicate to get the absolute maximum reimbursement that you can during this time. From a revenue implication, some things to think about. I'm recommending to many to hold their self-pay dunning holds as people are losing their jobs. Trying to maintain your liquidity on your self-pay, maybe hold your bad debt placements and delay those so that you can keep the AR on the books. Think through the implication of how that is for your models and your bad debt accruals, but do the right thing for the patients if in fact they're losing jobs. How does your revenue changes for prorations hit when they're now adding reimbursement bumps in certain areas for certain codes, not just by CPT, but for COVID diagnoses and for different place of services. And as we talk through some telehealth will be billed as E&Ms, or they will be billed as, non-facility, face-to-face or not face-to-face. How does that impact your underpayment systems? And then overall, from a cash flow perspective, how do these things impact your ability to bill and collect and be able to release these things so that you can focus on getting cash in the door to help your downturn in volume. From a people perspective, really we're changing where this work's done. Normally you would bill and collect based on a known set of coding criteria. We're now holding these post first coding. We're holding them in systems that aren't really designed to have a coder go back and recode things from a not so much diagnosis, but type of service, place of service, code, and then potentially on where and how the service was done, that coding may change even down future state. And so think through how the work will be done and where they'll need to then kind of put activity in places where you don't normally do it. And then one huge issue that I've seen is, I believe we have multiple daily meetings with managed care payers, and the data that we get from them in multiple states does seem to change. So be very prepared to have a myopic kind of laser focus with your managed care groups, and then making sure that they are able to then push all of that data back to the folks that need to make the changes within your systems. And then lastly, working on real-time changes in EMR for order sets, quick sets, appointment types, coding billing edits, along with kind of non-standard workflows, are needed for this rapid change for how a provider does a service, where that service was rendered, what type of device they utilized, either video, tele, or phone, or some other mechanism, so that you can then have an automated fashion through your EMRs the known pieces of data on the back end when you're holding those claims to be able to modify what I've talked through on the people impact, so that you'll get the revenue that you'll want from the code, and that you're maximizing those areas. Next slide. A couple of other things that folks are aware of. The first one, most people are aware Medicare's expanded the service to front load money up to 100 to 125% for your past Medicare patient or payments, I think for all hospitals. And then telemedicine reimbursement, certain telemedicines are approved to be reimbursed at office visit rates. I've also been given some other CPT codes. If you're a facility-based enterprise and you bill that, you need to work through with your payers exactly the type of reimbursement that they want from a place of service perspective for 21 or 11. During Medicaid, during this particular period, folks that put this diagnosis on will get an add-on. I spoke to how that will impact your expected payment in proration, but that really needs to be thought through retrospective, because you may or may not know that at the time of the service. And then this 1135 waiver for enrollment process has allowed care to be done in these alternative settings. It also allows different types of providers to do different types of service. It works really well for Medicare, but be super conscious of making sure that you talk to all of your commercial payers and your Medicaids. I have an example where a particular state won't pay a telemedicine claim unless a telemedicine waiver form is filled out for every single provider, significantly contrary to the Medicare rule. So be diligent to think through by payer, by location, by type of service, and the mechanism that service is then delivered. Many things to think about. Okay, that pretty much ends our kind of presentation. I know that thanks to Brian and Tim and Amanda and others, we'd like to open it up for questions. And Amanda, I'm going to turn it back over to you.
Thanks, Ian. Rebecca, do we have any questions coming through on the line?
We do. We have a question in regards to rheumatology services. Have you seen any information regarding treating infusion patients at home during COVID-19?
Tess or Sue, do you mind if I turn that over to you? Have either of you read or heard anything related to infusion patients?
This is Tess. I have not come across any information particular to infusion treatments at home, but it is something I would be happy to follow up with and then disseminate the information.
Sounds good. Another question, is the 95 modifier required on all claims or for certain payers?
is Sue. It came out from CMS, so it is a CMS directive. Most likely, commercial insurance carriers will follow, but that's one of those things that you may need to check with your individual plans.
Yeah, this is Ian Stewart. I will say that it is not mandatory for a number of payers. They would like you to bill the same way that you normally would bill, but you do need, my point on meeting with these payers on an ongoing, almost daily basis is to take these questions to them as they come up and make sure that they're very clear and distinct on Medicare has this rule, they'll use X modifier, what do you require, and how will it get through the billing system so it'll be adjudicated without getting a rejection so that you can maintain your cash flow. It's critical that you build a payer grid and go payer by payer for each of these issues.
The next question, please define non-traditional telemedicine services that would receive the 95 modifier.
So your non-traditional telemedicine are any of those services that are included in the Medicare expansion. So with their flexibility and expanding telehealth to certain clinicians, places of service other than the rural hospitals. So it's any of those services that are just kind of allowed under this emergency scenario. Does that make sense?
I think so. For the next question, for billing lab claims with U001, U002, and 87635 billed on the facility side require a CR modifier and DR condition code.
At this time, the U codes are being fast tracked into my knowledge. They're not effective currently. Sue, as far as the 87, was that you were talking about the condition code and modifier? Is that, I just want to make sure I heard the second part of that question.
The 87635 billed on the facility side require a CR modifier and DR condition code.
Sue, would you happen to know? I'm more on the pro fee, so I'm not off the top of my head. I'm not quite sure. I could look
on you. I'm sorry. Yeah, it is still a requirement for the condition code and the modifier on the facility bill. Again, this may change, but that's the latest directive that we've seen from CMS.
We also have another question. How do I support my staff who have never worked from home? For example, have a policy of expectations, take a survey of their needs or work from home space, understand adjusted time off or sick pay policies related to COVID-19.
Yeah, that's one where I think we've seen a lot of just variability and folks trying to on the fly be supportive of staff. In that question was mentioned, taking surveys of folks. I mean, that we've seen that critical, understand people's needs and flexible arrangements and just what's going to work for them. It's not always a one size fits all. And then, of course, having HR support on adjusting any policies, procedures, job expectations to accommodate those. Realize that it's all happening very quickly. So the more people from the organization that can weigh in on some of that, and we get the folks at the staff level, what are their needs defined, the more successful you all will be.
In some ideas there, I do some go-to meetings where we have folks pull their screens up if they have, almost everyone has a laptop and a monitor, so that we get a face-to-face during the week with different teams. And then I've been pretty lax on the productivity standard for the first week or two, just on a personal level, because I want them to get used to being at home and getting there. But I'll be honest, the productivity's increased for many of our folks. And they've likened it to, they just don't have so many people bothering them during the day, and they're able to just kind of lock in their home office and they get some things done. So I've seen an interesting uptick in some folks that have a great ability to work from home and can be dedicated to space. And I think in time, we really need to watch the underperformers as we would normally in our business offices, and go person by person and work out what their issues are.
This is Tim. I would also add to Brian and Ian's comment, we'll have the business continuity plan we send out, but what we found is there's various degrees of preparation in terms of, not only the work from home space, but VPN setups and the software to ensure that your continued operations. So part of that checklist will have some of those basic steps included to make sure that you're set up to, move people to a more virtual environment. The other thing I think an outcome of COVID-19 is going to do is I think it's actually going to change our environment for the good. I think you're going to see people, albeit forced to set up to this type of environment. It's going to be the new norm as we move forward. You'll see more and more virtual rev cycle or back-end business offices, whatever it may be. So we'll make sure we get that information out as well.
Another question, do you know if CMS is going to cover virtual therapy services provided by facility-based therapy staff?
At this point, I believe it was on the 31st, Medicare CMS did expand the therapy codes, and there are additional services that can be billed during the therapy CPT codes. There are some additional services that can be billed along with it. They do have to be audio and visual services, though. You can't. There was one extension for telehealth just recently that allowed for audio, video, or just audio services. However, when it comes to the therapy codes, it's just the audio and video only. And it does, to my knowledge, it is applicable to facility staff.
Correct, and the commercial payers are following suit with video, audio, video as the absolute the way to do it.
Right.
Thank you. Another question, can you talk more about the scope of the Medicare accelerated payments? Who exactly is eligible?
So I think, Rebecca, what they may be asking in that question with the Medicaid accelerated or advanced payment program is that it does cover both the acute side as well as your ambulatory facilities and physician practice groups, your medical groups as well. And so the requirement on the forms when you're filling them out just includes you to complete one per NPI. But to my knowledge and working with our client base, they've been successful, across the continuum of their facilities and services.
Thank you. This question is in relation to the one right before. Does the therapy have to be billed on 1500 only, or can it be billed on AUB? We are hearing that it can only be billed on a 1500 form.
I know the information particular to the 1500. I have not seen anything stating that it could be on the UB, but that I don't take that as gospel right now. I would have to double check to clarify that, the UB point.
Thank you. Another question, what type of impact do you see post-COVID-19 on revenue cycle?
Yeah, I can take this one. A lot of our team has been putting, our time and effort into the daily revenue cycle side, but we've also been thinking a lot what is going to change overall for the future. So a couple things that I would point are kind of top of mind for our team as we gather and talk about this is, I think virtual business office, as we talked about, it's forcing people to move quicker and more effectively into that type of setup. Telehealth, as a lot of this call is revolved around, we're seeing that's going to be the new norm. One of the things that we're also starting to think about, and I'm going to probably include on a future webinar coming up, is surge planning. So right now, it's a different environment. It's a different type of volume mix coming through our hospitals and health systems. But what does this look like post-COVID-19? So you have elective surgeries that have been put on the side. We're talking to patient access professionals across the US are saying, are we going to have a different kind of standard set of hours of operations? So are we going to be working, later in the evening to fit all this in over the weekends? And then what type of, surge and what does that look like as it flows through the rev cycle? So we're talking about shifting staffing now and how that's going to be important, but what does it look like as we see volume pick up post COVID-19? So I would say that's one. And then we're also talking, staffing wise, leveraging technology. So making sure technology is set up to be more efficient. Ian talked about ramping up the kind of protocol for productivity. Brian talked about that as part of the continuation plan, but making sure your systems can track it, making sure that we're taking automation to the next level to make sure that the right account's getting to the right person at the right time, especially when you're in a virtual environment. So those are probably the 4 to 6 things that we're starting to think about and put top of mind, and kind of where we see the evolution of rev cycle and this webinar and the information for the people on this call coming to.
Thank you, guys. There are no additional questions at this time.
All right. Well, this is Tim again. I just want to close it out, say thank you to everybody. Really appreciate the engagement. I can tell by the questions that came across. And we hope that you're able to take, again, this information, tactical in nature. We will follow up with the material. We'll also make sure a question or two in there that we needed to do a little more research on in terms of protocol or stipulations. We'll check into that and get that out to the team. And then again, for the benefit of our client base, for the revenue cycle industry, our intent is to do this, weekly going forward, making sure that we're staying on top of these issues. We know everything is changing, so we appreciate your patience there. But again, thank you to everyone. Stay safe, stay healthy, and we look forward to connecting with you in the future. Thanks, Rebecca.
Thank you for joining today's call. Again, as a reminder, today's call was recorded. Please be on the lookout for a link to the recording in your inbox. You may now disconnect. Thank you to our presenters.